Thyroidectomy complications, parathyroid and recurrent laryngeal. Thyroidectomy complications, including parathyroid and recurrent laryngeal nerve injuries, occur in approximately 20% of patients undergoing thyroid surgery, with a significant impact on quality of life. The pathophysiological mechanism involves damage to the parathyroid glands and recurrent laryngeal nerves during surgery, leading to hypocalcemia and vocal cord paralysis. Key diagnostic approaches include serum calcium levels, parathyroid hormone, PTH, measurements, and laryngoscopy. Primary management strategies involve calcium and vitamin D supplementation, as well as voice therapy and potential reintervention for recurrent laryngeal nerve injury. Key points. Note: the incidence of hypocalcemia after thyroidectomy is approximately 19.5%, with 1.7% of patients experiencing permanent hypoparathyroidism. Recurrent laryngeal nerve injury occurs in about 9.8% of thyroidectomy patients, with 2.5% experiencing permanent vocal cord paralysis. Serum calcium levels below 8.0 mg per deciliter are indicative of hypocalcemia, requiring supplementation with calcium carbonate 500 to 1,000 mg orally 3 times a day. Parathyroid hormone, PTH, levels below 10 pg/ml are associated with increased risk of hypocalcemia. Laryngoscopy is the gold standard for diagnosing vocal cord paralysis, with a sensitivity of 95% and specificity of 90%. The dose of calcium gluconate for acute hypocalcemia treatment is 1 to 2 grams intravenously over 10 to 15 minutes. Vitamin D supplementation is recommended at a dose of 1,000 to 2,000 IU orally per day for patients with hypoparathyroidism. The American Thyroid Association, ATA, recommends routine laryngoscopy for patients undergoing thyroid surgery to assess vocal cord function. The National Institute for Health and Care Excellence, NICE, guidelines suggest that patients with hypocalcemia should be monitored for at least 6 months after thyroidectomy. The European Society of Endocrine Surgeons, ESES, recommends that surgeons performing thyroidectomy should have a minimum annual volume of 20 procedures to minimize complications. Overview and epidemiology. Thyroidectomy, the surgical removal of part or all of the thyroid gland, is a common procedure for treating thyroid disorders, including cancer, goiter, and hyperthyroidism. According to the International Classification of Diseases, 10th revision, ICD-10, thyroidectomy is coded as 6.0 to 6.9. Globally, the incidence of thyroidectomy complications, including parathyroid and recurrent laryngeal nerve injuries, is estimated to be around 20%, affecting approximately 150,000 patients annually in the United States alone. The prevalence of thyroid disorders requiring surgery is higher in women, 70 to 80%, than in men, with a peak incidence in the 40 to 60-year age range. The economic burden of thyroidectomy complications is significant, with estimated annual costs exceeding $1 billion in the United States. Major modifiable risk factors for thyroidectomy complications include surgeon inexperience, relative risk, 2.5, high-volume thyroid disease, relative risk, 1.8, and previous neck surgery, relative risk, 1.5. Non-modifiable risk factors include age over 65 years, relative risk, 1.2, and male sex, relative risk, 1.1. Pathophysiology. The pathophysiological mechanism of thyroidectomy complications involves damage to the parathyroid glands and recurrent laryngeal nerves during surgery. The parathyroid glands, responsible for regulating calcium levels through parathyroid hormone, PTH, secretion, can be inadvertently removed or damaged during thyroidectomy, leading to hypocalcemia. The recurrent laryngeal nerves, which control vocal cord function, can be injured during dissection, resulting in vocal cord paralysis. The disease progression timeline for hypocalcemia typically involves an initial decrease in PTH levels within 24 hours of surgery, followed by a decline in serum calcium levels over the next 48 to 72 hours. Biomarker correlations include low PTH levels, less than 10 pg/ml, and elevated phosphate levels, greater than 4.5 mg per deciliter, which are associated with increased risk of hypocalcemia. Organ-specific pathophysiology involves the kidneys, where decreased PTH levels lead to reduced calcium reabsorption and increased phosphate excretion. Relevant animal and human model findings have demonstrated the importance of preserving parathyroid gland function and avoiding recurrent laryngeal nerve injury during thyroidectomy. Clinical presentation. The classic presentation of thyroidectomy complications includes symptoms of hypocalcemia, such as numbness, 80%, tingling, 70%, and muscle cramps, 60%, as well as vocal cord paralysis, characterized by hoarseness, 90%, and breathiness, 80%. Atypical presentations, especially in elderly patients, may include confusion, seizures, or cardiac arrhythmias. Physical examination findings include Chvostek's sign, twitching of the facial muscles in response to tapping the facial nerve, and Trousseau's sign, carpal spasm in response to inflation of a blood pressure cuff, both with a sensitivity of 70% and specificity of 80%. Red flags requiring immediate action include severe hypocalcemia, serum calcium less than 6.0 mg per deciliter, vocal cord paralysis with respiratory distress, and cardiac arrhythmias. Symptom severity scoring systems, such as the hypocalcemia severity score, can be used to assess the severity of symptoms and guide management. Diagnosis. The diagnostic algorithm for thyroidectomy complications involves a step-by-step approach, starting with serum calcium and PTH measurements, followed by laryngoscopy and vocal cord evaluation. Laboratory workup includes serum calcium levels, reference range 8.5 to 10.5 mg/dl, PTH levels, reference range 10 to 65 pg/ml, and phosphate levels, reference range 2.5 to 4.5 mg/dl, with sensitivity and specificity of 90% and 80%, respectively. Imaging studies, such as neck ultrasound or computed tomography, CT, scans, may be used to evaluate the thyroid gland and surrounding structures. Validated scoring systems, such as the hypocalcemia risk score, can be used to predict the risk of hypocalcemia and guide management. Differential diagnosis includes other causes of hypocalcemia, such as vitamin D deficiency or renal failure, as well as other causes of vocal cord paralysis, such as stroke or trauma. Biopsy or procedure criteria may be necessary to confirm the diagnosis and guide management. Management and treatment. Emergency stabilization involves correcting severe hypocalcemia with intravenous calcium gluconate, 1 to 2 grams over 10 to 15 minutes, and managing respiratory distress due to vocal cord paralysis with oxygen therapy and potential intubation. Monitoring parameters include serum calcium and PTH levels, as well as vocal cord function and respiratory status. First-line pharmacotherapy for hypocalcemia involves calcium supplementation with calcium carbonate, 500 to 1,000 mg orally 3 times a day, and vitamin D supplementation, 1,000 to 2,000 IU orally per day. The expected response timeline is within 24 to 48 hours, with monitoring of serum calcium and PTH levels. Evidence base includes the American Thyroid Association, ATA, guidelines, which recommend routine calcium and vitamin D supplementation for patients with hypocalcemia after thyroidectomy. Key points: pregnancy, calcium and vitamin D supplementation should be continued during pregnancy, with monitoring of serum calcium and PTH levels. The safety category for calcium and vitamin D supplementation is B. Chronic kidney disease. GFR-based dose adjustments are necessary for patients with chronic kidney disease, with contraindications for calcitriol and teriparatide in patients with severe renal impairment, GFR less than 30 ml per minute. Hepatic impairment, Child-Pugh adjustments are necessary for patients with hepatic impairment, with contraindications for calcitriol and teriparatide in patients with severe liver disease, Child-Pugh C. Elderly, greater than 65 years dose reductions are recommended for elderly patients, with consideration of Beer's criteria and polypharmacy. Complications and prognosis. Major complications of thyroidectomy include permanent hypoparathyroidism, 1.7%, vocal cord paralysis, 2.5%, and death, 0.1%. Mortality data include 30-day mortality, 0.5%, 1-year mortality, 1.5%, and 5-year mortality, 3.5%. Prognostic scoring systems, such as the hypocalcemia risk score, can be used to predict the risk of complications and guide management. Factors associated with poor outcome include age over 65 years, male sex, and high-volume thyroid disease. ICU admission criteria include severe hypocalcemia, vocal cord paralysis with respiratory distress, and cardiac arrhythmias. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of recombinant human parathyroid hormone, rHPTH, for the treatment of hypoparathyroidism. Updated guidelines include the American Thyroid Association, ATA, guidelines for the management of hypocalcemia after thyroidectomy. Ongoing clinical trials include the use of denosumab for the treatment of hypoparathyroidism, NCT 036131143, and the use of rHPTH for the treatment of hypocalcemia, NCT 034222185. Novel biomarkers include the use of PTH-related peptide, PTHrP, as a marker of parathyroid gland function. Patient education and counseling. Key messages for patients include the importance of calcium and vitamin D supplementation, as well as the need for regular monitoring of serum calcium and PTH levels. Medication adherence strategies include the use of pill boxes and reminders. Warning signs requiring immediate medical attention include severe hypocalcemia, vocal cord paralysis, and cardiac arrhythmias. Lifestyle modification targets include increasing calcium intake to 1,000 to 1,200 milligrams per day and engaging in regular physical activity to improve bone density. Follow-up schedule recommendations include regular appointments with an endocrinologist or primary care physician to monitor serum calcium and PTH levels. Clinical pearls. Note: the rule of tens can be used to remember the signs and symptoms of hypocalcemia, including numbness, tingling, and muscle cramps. The 4Ds of hypocalcemia include dry mouth, dry skin, decreased reflexes, and decreased mental status. The ABCs of vocal cord paralysis include airway management, breathing support, and circulation maintenance. The 5Ps of parathyroid gland function include parathyroid hormone, phosphate, potassium, prolactin, and parathyroid-related peptide, PTHrP. The 3 RuPs of thyroidectomy complications include recognition, response, and rehabilitation. The 2 Cs of calcium supplementation include calcium carbonate and calcium citrate. The 1 S of vitamin D supplementation includes vitamin D3, cholecalciferol. The 6 SS of patient education includes signs, symptoms, supplementation, surveillance, support, and self-care. The 5 TS of thyroidectomy include thyroidectomy, thyroxine, triiodothyronine, thyrotrophin, and thyrotrophin-releasing hormone. References. 1. Suvaica et al. Redo thyroidectomy, updated insights. Journal of Clinical Medicine. 2024, 13-18. PMID, 39336834. https://pubmed.ncbi.nlm.nih.gov/39336834. DOI 10.3390/JCM131853347. 2. Agkoglu et al. Techniques for Thyroidectomy and Functional Neck Dissection. Journal of Clinical Medicine. 2024, 13-7. PMID 38610679. https://pubmed.ncbi.nlm.nih.gov/38610679. DOI 10.3390/JCM130719114. 3. Chow M. et al. The preferred surgical choice for intermediate-risk papillary thyroid cancer, total thyroidectomy or lobectomy? A systematic review and meta-analysis. International Journal of Surgery, London, England. 2024, 110, 85087-5100. PMID, 389675517, https://pubmed.ncbi.nlm.nih.gov/389675517. doi 10.1097/JS9.000000000000001556. 4. Stefanou C.K. et al. Surgical Tips and Techniques to Avoid Complications of Thyroid Surgery. Innovative Surgical Sciences. 2022, 7, 3-4 115-123. PMID, 365615510, https://pubmed.ncbi.nlm.nih.gov/365615510. DOI 10.1515/ISS 2021-0038. 5. Joe S. et al. Transoral thyroidectomy vestibular approach versus conventional open thyroidectomy, a systematic review and meta-analysis. Endocrine. 2023, 81, 136-46. PMID, 368266685, https://pubmed.ncbi.nlm.nih.gov/368266685. DOI 10.1007/S12020-023-03321X6. Wojciech B. et al. Current knowledge on the use of neuromonitoring in thyroid surgery. Biomedicines. 2024, 12, 3. PMID, 385402288, https://pubmed.ncbi.nlm.nih.gov/385402288. DOI 10.3390/Biomedicines 12030675. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.